Okay, welcome back. This is part 2 of our interprofessional coordination of care. So we left off talking about discharge planning, and I was saying that discharge planning starts even before someone is admitted to an acute care setting or to really whatever setting they're in, because we always want to note this, we want to get our patient back to their baseline. What were they before they got sick? I want to get them back to their baseline and discharge them back to wherever they went before they came in to see us. So some essential components of our discharge plan then are to assess the strengths and limitations of the patient, family, or their support person. So, what's their educational background? How much experience do they have in healthcare? We can't assume that they have any level of knowledge without assessing what does that look like. Assess the environment that they're coming from and where they're going back to. Implement and coordinate the care plan. So remember who is involved in coordinating that plan of care. Get the right people engaged. And then you're going to consider individual, family, and community resources. So my plan is going to look different if I have an individual who is 80, lives alone, and just had a stroke that is going to impair their ability to care for themselves, versus someone who just got diagnosed with congestive heart failure, which is a chronic illness, but they have, 3 kids and their spouse at home that are very engaged in taking care of the person and really want them to make changes so that they can live as long as they can with as few complications as possible. So you can see, you really have to assess what's going on with your patient and what's their situation like so that you can individualize your plan of care. And then you want to not only provide a plan of care, which you're doing in conjunction with your people, so your patient and whomever they consider to be their family, so that they know what the goal is, they have helped to determine what those goals are, and they have bought into making the changes necessary so that they can have effective outcomes. Okay, so there's that. Now, criteria for formal discharge plan and referrals. So what do they know and what do they need to know? So where's the gaps and who needs to teach them? If they're going back home and they just got diagnosed with diabetes or congestive heart failure, those are very complicated chronic illnesses that require a lot of education. So we want to make sure that when they go home, they don't have a relapse and end up back in the hospital because they didn't have the knowledge they needed. So we want to set up home health. Home health's biggest thing, I feel like, is education. So we get them set up with home health before they even go anywhere. Also, social isolation. Maybe they were super involved in the community where they lived, and now with their stroke, they've lost their ability to speak. So they feel very socially isolated. So we need to take all of those things into consideration as we treat people holistically. So we're looking at them from an emotional perspective, a psychosocial perspective, spiritual and physical. I've already mentioned this as my example. Recently diagnosed with chronic disease is a huge reason why we make sure that they've got a continuity plan in place so that they don't end up back acutely ill. Or if they've had a major surgery, someone who maybe had a heart attack and they had to have bypass surgery. That takes so long to recover from. So we send them to cardiac rehab. Or maybe they broke their hip and now they're going to have to go to rehab at a skilled nursing facility to learn how to walk again. Anything that's going to cause a prolonged recuperation. So we got to make sure we have great discharge planning. Or maybe they have a wound and that wound is going to take a long time to heal because their circulation is compromised and it's on their foot. So we are setting up home health to go out and do education and dressing changes. Or maybe they have financial difficulties. They don't have referral sources, or they have a terminal illness, which is when they get referred to hospice. So here's our guidelines for discharge planning. Do you think it's a good idea to wait until we're getting ready to send them out the door to go over their discharge plan with them? I'll just tell you it isn't, because at the end, you just want to get out of there. Like, take my IV out. I'm already dressed, and I got my bag because the doctor said I could leave, and, it's 7 a.m., and they're not going anywhere till 1 p.m. But they're ready to go. So they have shut down. They're not listening to your plan or your education. So you want to be educating every single shift, every single time you go in the room. We're going to assess and identify what they're going to need when they leave. We're going to set our goals with the patient and the family and teach them where they have gaps in their knowledge, provide home care, healthcare referrals, and then it'll be really up to that home health agency and whoever's taking care of them when they get home to evaluate, was it effective? And how do we know it was effective? Well, if they end up back in the hospital, then it probably wasn't effective. So leaving AMA, that's against medical advice. Anybody can leave against medical advice. I would give the caveat that if they are being held on a mental health evaluation, that's the only time they're not really allowed to leave against medical advice. They do carry a risk for increased illness or complications, of course, because they haven't been discharged, so there's still care that needs to happen. They do need to sign a release form. We have to make sure that we take out their IV if they have a peripheral IV, and that we inform them of the risks that they're taking before they leave. We have to make sure the signature is witnessed, and then the form becomes part of their medical record. Telehealth. I feel like everybody now knows what telehealth is. We had a lot of issues getting telehealth off the ground until what? Until COVID. COVID pushed the need for telehealth. Before, there was a ton of red tape, and there were a lot of regulations in place that were kind of making it difficult to get it implemented. But man, once COVID hit, we got that implemented quick, because it no longer mattered that we needed all these other things done. At the end of the day, we just needed to get people care. So telehealth is where you have somebody either on a phone, maybe you're doing FaceTime, or on a computer, and you're able to remotely receive care. This includes your regular wellness visits, prescriptions for medication. I didn't know you could do eye exams. That's super interesting to me. Counseling or some urgent care conditions. So our insurance here at MCC, we have something called 98.6, and that is where we can call and just talk to a medical professional over the phone, and maybe we just need, we need something because we threw out our back. We can call and set that up, and they'll call in our prescription, and we don't even have to leave work. So it is super convenient. It limits risk to exposure to illnesses, thus, why it got implemented during COVID. Shorter wait times, and it increases access. So if I live on the Navajo Indian Reservation, granted I need internet access or telephone, but if I have that, I can now talk to my doctor in Phoenix without having to go to Phoenix. So super convenient, and I get increased access. Excuse me. So there's some examples of home healthcare services you can look at. Seeing if there's anything skilled professional, paraprofessional. That would be like your physical therapy, your occupational therapy, or speech therapy. Custodial services. That might be Meals on Wheels. I'm not quite sure. Something like that. Or, somebody's coming in to clean your house or something. Home medical services. So this is, I need home oxygen, and you're going to come and bring me my oxygen and supplies. All right, concepts of home health. I feel like we probably knocked this out of the park. Safety considerations. How about, I'm on oxygen and I smoke. There might be some safety considerations. I need home health to come out and make sure that that's not happening. Infection prevention. Maybe I just had C. diff and I'm not over it and I'm going home. Home health's going to come out and make sure that we're taking measures necessary to prevent spreading infection. Or maybe I have MRSA and they're coming out to do my dressing changes and educating the family on how to prevent Like, don't share a towel, or make sure you wash your towel every time you shower. Reimbursement sources. That's going to be private pay and paying out of pocket. Insurance, private insurance, or Medicare or Medicaid, no matter what it is, if it's going to be reimbursed, it requires a ton of documentation so that you can justify the services you provided and be reimbursed for those services. And then I'm not sure what legal considerations, but you're welcome to look in your textbook and see what it says about legal considerations. I'm going to assume that that's talking about making sure you're doing your documentation and that you're ensuring that you're leaving your patient in a safe setup and that you documented it as such so that you're not legally responsible if something should happen to your patient after you leave, like they smoke a cigarette while they've got 5 liters of oxygen on and it blows up and burns them. Not that that's ever happened, but let me just tell you, yes, it has. I feel like that's the last slide. I hate to leave on that note because it seemed kind of negative, but we're done with this chapter. So if you have any questions, we'll address them during class. Write down your notes and bring them with you. Thank you so much and see you in class.